Today, Bron and I will be taking you through how to manage cannabis withdrawal, or certainly how we do it here at the Clean Slate Clinic. We'll be talking a bit about cannabis and its effects, talking about some hot topics like medicinal cannabis. My name's Chris. I'm a GP by training. I'm currently working as an addiction consultant at St Vincent's Hospital in Sydney, and I'm the medical director of Clean Slate Clinic. Bron, do you want to introduce yourself?
Yeah, hi
I've got your
everyone.
bio.
What's that? You've got my my name's Bronwyn Hudson. I'm a rural generalist in northern New South Wales and an addiction medicine physician with Clean Slate. Yeah, echo Chris's thanks in you all joining us this evening. Super stoked to be here and sharing this evening with you.
I'll just start with an acknowledgement of country as we respectfully acknowledge Australia's First Nations people as the traditional owners of this land. I'm joining you from the Gadigal land of the Eora Nation, and we pay respect to their enduring connections to country through songs, stories, spirituality, ongoing cultural practices. Sovereignty was never ceded. This always was and always will be Aboriginal land. So before we start, we do have a Q&A function at the bottom of the screen. So please use that. I think you are all on mute just to avoid any background noise and commotion. But please put questions in the Q&A. I'll either answer them in text or we'll answer them live. Bron's going to take you through the main body of the presentation, and I'll just be annoying and butt in occasionally. So thanks very much, Bron.
Thanks, Chris. Butting in is welcome from Chris. And yeah, if you've got any questions, please pop them in the chat. And one of the things I love about Clean Slate is the collaboration. So yeah, super thrilled to be with you all this evening and talking about cannabis and cannabis use in Australia. Hopefully, by the end of the next hour, we will have a little update for us all on trends in cannabis use in Australia. We're going to do a deep dive into the management of cannabis use with a real focus on primary care, where a lot of the heavy lifting in the management of cannabis in our communities is done. And then we are going to run you through the offerings of Clean Slate when it comes to cannabis withdrawal. And we'll walk you through our program. We'll share some insights, some learnings that we have made and continue to make along the way. And then we will close with some questions. So I guess we all know what cannabis is. And I was saying to Chris yesterday that I think you'd have to be living under a rock to have not had to consider the changing landscape of cannabis with the explosion of prescribed cannabis in our communities and, around Australia and the world. I remember the last time I kind of walking the streets, and now it seems to be that the smell of cannabis smoke or vape is much more common than the smell of nicotine smoke, which I guess is a good thing, but it just represents the changes that are happening in our community. Lots of different names for cannabis, and points and prizes for anybody who can tell me who Mary Jane is and why. Her name is a slang word to describe cannabis, and I'm sure a lot of you are familiar with the slang terms that we use to describe cannabis. And I think one of the biggest changes has been in how cannabis is consumed by our patients and the people in our community who use cannabis. I think going back, 15, 20 years, the majority of people would be using cannabis by smoking it with the occasional, cookie or oil or butter thrown in. But I think the increase of vaped cannabis products, not just with the advent of prescribed cannabis, but with also the increase in vaped products available in the market just generally. And of course, it's still continued to be eaten and applied topically. I am I should also add my acknowledgement to the traditional owners of the land. I'm coming to you from northern New South Wales, which is Bundjalung country of the Arakwal people. And my community is home to the famous Nimbin. So we are very familiar with cannabis up here, and I learn so much from my patients and from the community. But some of the forms of topical cannabis that have appeared over the years intrigue and fascinate me. But it's certainly available in prescribed topical form now. Yeah, I've seen a fair bit of it recently for the treatment of post-herpetic neuralgia, which seems to be helping. I'm not sure what the evidence is for that, but I've just been interested to see that being used.
And does that have a systemic effect then, Bron?
I think it would have some form of systemic effect,
Yeah.
but you know, the few patients that I've seen it prescribed for has been for just that local relief of that that awful pain associated with a herpetic neuralgia. And I'm speaking with some kind of you know, personal experience here because my mum's recently had shingles and it was her GP. I was delighted that her GP was experimenting with, you know, other forms of treatment. Sorry, Mum, I'm disclosing your personal health information in a webinar. I'm sure she'll forgive me. So why do people use cannabis? Why do people use cannabis for personal use or recreationally? And why is it considered to be prescribed? Well, it acts on the endogenous cannabinoid system or the endocannabinoid system, which again wasn't something that I learnt about at med school. It's been something that's recently, you know, come into our knowledge and come into our literature. And you know, I think there are now over 100 different types of cannabinoids that have been identified from the, you know, the traditional sativa cannabis plant. Yeah, I think, and then over 300 non-cannabinoid chemicals that are in the plant. So we're talking about a complex plant here, and today's webinar is not about that at all. But I just want to preface the information with this is a complex, yeah, plant. It's a complex medication. It's a complex substance, and the reasons that people use it and the effects that it have are really varied. And as with most things, there is no one size fits all, and it's applying the right horse to the right course. So I've just the last little point there on that slide is medical versus non-medical, and I often struggle with the nomenclature or how to refer to substances. Like, is it illicit? I don't like that word because it's kind of got that hint of you know, this is something bad or this is something naughty. Is it prescribed versus non-prescribed? If somebody's taking it to treat a medical condition, but it's not prescribed, does that mean it's non-medical? So I think, you know, we can get bogged down in what things are called and what names we have. But, you know, at the end of the day, THC is THC, CBD is CBD, whether it's prescribed, not prescribed, it's going to have some similar features and some similar medical implications, some similar psychological, mental health implications, and certainly similar implications for the development of a cannabis use disorder. So hopefully that sets the scene a little. Why do people use cannabis? Well, again, the reasons are very varied, and we discriminate, I guess, between the short-term effects and the long-term effects. In the short term, the use of cannabis, and this is mainly THC we're talking about here in terms of its euphoria and relaxation and that concept of altered perception. It's definitely the THC or the delta-9 tetrahydrocannabinol, which is the close enough. That gets people stoned, for want of a, I guess, more medical term. But the CBD, which is the non-psychoactive part of the plant, also does have a lot of useful properties as well in terms of the calming. And I find it always really useful to ask patients, what is it that cannabis does for you, and why are you using it? Is it a numbing? Is it to get high? Is it to relax? Is it to stimulate your appetite? And just really drilling down into the reasons why patients are using cannabis and understanding their effects of the use, both the short term and the long term. And with any medication, substance, prescribed, non-prescribed, prescribed for another reason, but there's always going to be side effects or complications of using that. And in severe cases leading to a dependence or a cannabis use disorder. But let's not forget some of the other, respiratory, gastrointestinal, cannabinoid hyperemesis syndrome is a really big thing that we treat really regularly up here in our emergency departments. But the ongoing cognitive impairment, memory impairment, and links to other cancers, whether they're respiratory due to the route of administration or whether they're cardiovascular, and then of course the exacerbation of existing mental health conditions, or the unveiling or revealing of mental health conditions that may or may not have become apparent if it wasn't for the cannabis use. So a few little statistics just on the trends of cannabis use in Australia. We get some pretty good information about trends in substance use from the National Drug Strategy Household Survey. I think the last one kind of really was commented on in 2024, the data that was collected in 2022. And that showed an increase in the lifetime use of cannabis from the previous survey done in 2019. And that survey showed 12% of the Australian population having used cannabis in the previous 12 months. I did do that math, and now I think it was it 250,000? I can't, can you remember what I said?
I think 2 million, I think, wasn't it?
2.5 million?
Yeah.
2.5 million Australians in the last 12 months. That's that's a lot of people having used cannabis in the previous 12 months, and 41% having used it in their lifetime. And I think the really interesting thing that people much cleverer than me were able to extrapolate from the data in the drugs strategy survey was that the patterns of use are varying with age. So when you put everybody in together, that 12% or that 41% lifetime usage statistic is interesting. But then when you break it down, there's been a decline in youth smoking, which or decline in youth use of cannabis, which is a good thing, I guess. But the older people, the older cohort of patients, are the ones that are driving the increase, with very few of them changing and many of them increasing in their use. The Australian Institute of Health and Welfare information that gives us information on treatment and access to treatment shows that cannabis is the most common primary drug of concern in 17% of treatment episodes. And that counselling was the most common treatment type, and that was 45% of people seeking treatment or having treatment for their cannabis use. And I think the second one, which was, I think, in the teens somewhere, was just having an assessment. So their treatment entailed an assessment. So despite the fact that we don't really have any great medications for cannabis or cannabis use disorder, people are presenting for treatment, and the research is ongoing as to things that we can offer. And we'll talk about that a little bit more in the webinar. I think it's always important to point out at-risk groups, and they've been identified in the Health and Welfare Survey as being Aboriginal and Torres Strait Islander people, younger people, people in contact with the justice system, and people who inject drugs. I think the statistic on people who are in treatment for substance use disorder, whether that's opioids or amphetamines, that the rate of them using cannabis, I think, is up and perhaps over 50%. So, it's not hard to then consider that, a lot of people are using cannabis, and a lot of people that we're seeing in general practice in primary care are going to have been exposed to cannabis either themselves or in their communities or their families in the last 12 months and have used it at some point or another in their lives. So diagnosing cannabis use disorder, when do we as primary carers need to worry about our patients' use of cannabis? And how do we actually diagnose that? What's the difference between somebody just using Mary Jane on the weekend or somebody actually presenting with problems? And is there a difference between cannabis use disorder that comes from people using cannabis for personal use or recreationally or non-prescribed or non-medical cannabis, as opposed to the cannabis that is prescribed? And there's a plethora of options for people to access prescribed cannabis medicines now, and the explosion of prescriptions that's reflected in the TGA data. It's evident, and we also know from the TGA data that the majority of prescriptions are for THC containing medications, and some with quite strong or quite high potency. So I like to go to the ICD-11 or the DSM-5 to diagnose cannabis use disorder. The DSM-5 is something that we're all familiar with, and diagnosing cannabis use disorder follows similar themes to diagnosing alcohol use disorder. ICD-11 uses terms like dependence rather than use disorder. I think DSM-5 has definitely simplified their terminology, which I actually think is helpful. I think it's unhelpful when coding in certain organizations and health networks and NGOs uses ICD-11, and there's a mismatch between the terminology in the two. But I think just stay with what you know, stick with what works. At the end of the day, for me, cannabis use disorder or alcohol use disorder or opioid use disorder or amphetamine use disorder can be summed up with one sentence, and that's continued use despite harm. So continuing to use something despite it causing people harm, whether that's physical harm, emotional harm, harm to their families, harm to their workplaces. But there's 11 criteria there with the DSM-5, and that's using larger amounts and for longer periods, not being able to stop or cut down despite wanting to. So I think the language about that is repeated attempts at trying to stop. The increased in time spent using the substance, whether that's seeking the substance, using the substance, recovering from the substance, having cravings and urges, and not managing other responsibilities, whether that's family, work, community responsibilities, and continued use despite problems in relationships, so acknowledging the impact that cannabis use can have on relationships, and giving up activities because of use. And that's a nice signpost, usually, that things are becoming problematic. And one of the questions that I ask around that is, do you use at home? And Chris, I don't know if your practice, your patients kind of reflects a similar thing, but people with alcohol and cannabis, I used to smoke at parties, or I used to drink at parties, and then it got to the point where I just stay home because I didn't want anyone else to see me using. I didn't want anyone to comment. I didn't want the amount that I was using to become obvious. So not going to parties or not going to dinner parties.
People stop, they won't answer the phone, or they won't go online when they're smoking, and they socialize less. They tend to use on their own when the use disorder is as you say, affecting those relationships. That's one thing that I sort of talk about a little bit, because people might not recognize that it's affecting their relationships because they don't see anybody anymore. So I sort of reflect that back.
Yeah, nice. Using cannabis in dangerous situations, so it's driving, and our laws and policy around driving and cannabis is still, THC is a banned substance in driving. It's still very much in the hands of the kind of police and justice system rather than in health hands. Continuing to use when you have a physical or psychological problem made worse by cannabis, and tolerance and withdrawal. And the tolerance and withdrawal is interesting. People, there definitely is a tolerance to cannabis. I definitely see patients becoming tolerant to cannabis and cannabis use, and we definitely see withdrawal. And we're going to be talking about withdrawal a little bit later in the talk. So prescribed cannabis, is it different? So a lot of this information comes from the Anonymous Cannabis as Medicine survey that is run by who, Chris? Mental blank. I know it's
Fair.
Nick and his
What what
yeah.
was the question?
Who runs the Anonymous Cannabis as Medicine survey?
Oh, I don't know.
Got
Maybe
a
it's
mental blank. I'll come back to this, but a lot of really great data on prescribed cannabis, and I think one of the interesting things is for me, and I'm referencing here Nick Lintzeris, who does a lot of research in this area. Hearing him speak at the APSAD conference, which is one of the addiction conferences in Canberra last year, that 22% of people who try cannabis non-medically will develop a cannabis use disorder, and 29% of people who use medical cannabis will develop a cannabis use disorder. So I think that's really interesting, in that just because it's prescribed doesn't mean that people aren't going to get into trouble with it. And we know this, we've got a lovely history of getting it wrong in the past with opioids and benzos. And I think a lot of the caution around prescribing cannabis has come from that experience. So I think that's wise to be cautious. Are we being too cautious? I don't know. A lot of these questions we won't answer.
Yeah, certainly there's a sense that for when we're using medicinal cannabis for chronic pain, that it's the lesser of two evils when it comes to using opioids for chronic pain, where there's no evidence really for using opioids in chronic pain if it's non-cancer pain. And so certainly when I was prescribing cannabis as a GP, that was in my head. I'd rather that they were smoking cannabis or using cannabis than using opioids. But again, that can lead you into trouble as well, because you take your eye off the ball a little bit, thinking that it's safe. And it's interesting, isn't it, that more people who use medical cannabis develop CUD than people who use street or recreational cannabis. And we sort of talked about that yesterday, didn't we? And maybe that is because if it's been prescribed by a doctor, then surely it's okay and surely it's safe. And you do see on SafeScript, I see patients who have three different cannabis prescribers, or they have three different types of cannabis prescribed for different strengths for different indications. So they'll have their strong THC before bed, or their lighter one for their pain, and so you can see how people can quickly develop the use disorders.
Yeah. I think some of the doses that are being prescribed are quite extraordinary. But I do agree that I would rather have a patient with chronic pain on cannabis than a patient with chronic pain on opioids. I think, from a harm reduction point of view, which again we're going to talk about a little bit later, I agree. There's really sound logic and reasoning there. But I think that the trick is to just because it's safer doesn't make it completely safe. And keeping our eye on the ball is really important.
And important to say that they're both off-label treatments for chronic pain. So, there's plenty of on-label or licensed management techniques for chronic pain that have a good evidence base. So far, cannabis doesn't have a good evidence base yet for chronic pain. And opioids indeed have an evidence base which says that they should not be used for chronic pain. So at least cannabis wins that argument a little bit as well. The lesser of the two off-label sins.
Definitely. So we're going to turn our attention now to the management of cannabis use and cannabis use disorder. We're going to have a little look at the Clean Slate Protocol that we use. Managing cannabis withdrawal I find it so rewarding and so satisfying. And whether that's something that you do in your practice or you want to do in your practice, like we encourage you to take notes, use the protocol. one of the things I absolutely adore about Clean Slate is its mission and philosophy of breaking down barriers to accessing treatment and meeting patients where they're at, if that's geographically or where they are in their relationship with cannabis. Often the barrier to getting help is either not knowing where help is or not having access in that particular community. So we're delighted to share the protocol with you. So we're going to talk a little bit about that. We're going to talk about the withdrawal symptoms, the time course of withdrawal, which I think is so important to know when you're managing patients in the community, because unlike alcohol, that physical withdrawal, 3 to 5 days, done and dusted, and then we move on to the psychological recovery. Cannabis withdrawal, really quite different in the time it takes to come on, the phases that it goes through, and then the protracted nature of the withdrawal. Whoop. Trigger happy. So I think at the outset, when you've got a patient before you, you've established they've got a problem with cannabis, or they've come to see you specifically for their cannabis. I think it's so important to know, what are we treating and what are our goals? Is this patient dependent? That doesn't mean do they have a cannabis use disorder, but are they neuroadapted to their cannabis use and therefore will have a withdrawal syndrome which needs to be managed? The majority of people that stop using cannabis don't need any help. They don't attend, they don't talk about it. They just decide that they're going to stop and they stop, and they might be uncomfortable, or they might be experiencing withdrawal syndrome that they're not aware that that's a withdrawal syndrome, but they stop without help. Does a cannabis use disorder exist, and are they going to need a little bit more support? And this is a goal that I love. Is their goal abstinence? Great if it is. No harm can come to you if you're not using a substance. Or is it just gaining control and not necessarily being completely abstinent from the substance? And that applies across the board to all of the substances that we treat. And getting control over use and decreasing the amount that's used, or using safer forms is certainly a very valid and worthwhile goal. And it's our job to walk with people to help them achieve their goal, whatever that is. And at every opportunity, there's opportunities for harm minimization. And traditionally, harm minimization has a lot of different arms to it. And in the current climate, when you're talking about harm min for cannabis users, it's if they're smoking, have you thought about vaping? In many ways, prescribed cannabis is a harm minimization strategy because it's a safer supply of medication. I personally don't prescribe cannabis purely for the reason of giving somebody a safer supply of cannabis, but I have no problem with that. If I did that, I just wouldn't have any time to see other patients. But I think there are people who are appropriate to be using cannabis, and not everyone is appropriate for using to be using cannabis. But if someone's using cannabis and they don't have a cannabis use disorder and they don't have dependence, and they're just after a safe supply, that is a harm minimization strategy. And I think always with our young people, opportunities for having discussions around substances. I'm totally polished up on this topic at the moment with two teenagers in the Northern Rivers. There's a harm minimization conversations that I'm having with young people all the time. And it's a bit of a sidetrack, but the message there is clear and evidence-based, that if people can delay their use of substances, whether it's cannabis, whether it's alcohol, for as long as possible, then their risk of developing problems later down the track is decreased. And looking at the strength of the cannabis that people are smoking, I think from a harm minimization perspective, this is in prescribed sense, if people are smoking or using or vaping or eating or using cannabis at a certain strength, and knowing the strength of what they're using, and knowing that strength when it's bought illicitly will vary from time to time. But I think it's also important to remember that somebody who is using cannabis and smoking it, we can still intervene with harm minimization strategies when abstinence is not the goal. And that's about, kind of safer settings for using. It's about safer smoking techniques. It's about caring for equipment. It's about using, when you've got a new supply, using some cannabis and then waiting, 10 minutes before you have your next smoke or your next bong or your next joint. Screen or gauze in pipes or bongs can help that particulate matter and that ash that comes up into somebody's lung can decrease the risk of that and therefore decreasing harm. THC is absorbed super quickly in our respiratory systems. And that whole, I can't actually say this long, deep talks without my mind being cast back to high school and seeing people down the back of the sheds like, and holding on for it as long as they can.
Yes. And then passing out.
And then passing out. But that long, deep holding on, it actually doesn't really give them any benefit in the effect that they're going to get from THC. It might make them cough some more, but it's certainly, going to increase their harm. So even just educating young people about not doing that is helpful. And, having ice in the bong, in the water of a bong, decreases the amount of particulate matter and ash that gets transferred. So,
as in frozen water.
That's right. As in,
yes. Good. Just checking.
Oh, good point.
That's a new one on me.
Ice is in H2O, not crystal methamphetamine.
Yeah.
But, if just from a harm reduction point of view, I don't think I put it on there. I meant to come back and put this on, but there was recently a case in Sydney, which a lot of you may be familiar with, of some young people using what they thought was a cannabis vape pen, which ended up having nitazines in it, which is a highly potent synthetic opioid wreaking havoc in the supply of substances at the moment. So they overdosed and needed Narcan. So I think, the being alert and aware that we don't know what's in a lot of the illicit or non-prescribed supply, and is another argument for safe supply, isn't it? If that's where you choose to, if that's where you.
I've never gone as far as offering a cannabis smoker take home naloxone, but I think I might if it was, someone a younger person, by way of explaining what happened with the nitazines and saying, you might want to think if you're going to use synthetic cannabis about having some take home naloxone and explaining the seriousness of what actually happened to those young people. And we know there's been cocaine contaminated with nitazines and some deaths indeed. So probably wouldn't recommend take home naloxone for all our cannabis smokers, but if they are mixing with people who are injecting drugs or using opioids, then it certainly wouldn't hurt.
Definitely. And I think too, just having that conversation with people about how they're accessing, is it in a vape pen? Are you buying it on TikTok or Snapchat, which I think was the source of the vape pens, just assessing their supply chain. And I think, we're lucky up here because we've got the hemp embassy. So it's a safer supply, definitely safer supply of non-prescribed medication. So
it's a great point though. If you're buying things online, you've got access to the whole world of drugs. A lot of benzos being supplied through the dark web. I think you can pretty much get anything through the dark web. And the 16, 17, 18-year-olds certainly would know how to access that better than people of our ilk and age. And just these lovely harm minimization conversations are so beneficial because these are things that people don't think about. But they want to get high, they're with their friends, they're just doing what their friends are doing. So just getting people to stop and think, I think is so valuable.
Yeah, the 15-year-old at the high school at the local Billy Bush, they're not thinking about these, and there's, you know, still potentially 10 years off their executive functioning and frontal lobes being fully, you know, evolved. So, you know, we can't, we can't even really ask them, you know, to do anything other than try and keep themselves safe. But yeah, I do, certainly have that conversation. But there was also some contaminated cannabis supply up here with there was a bit of a war between some of the suppliers at the local high schools, plural, and there was amphetamines being kind of mixed in with the cannabis to make their cannabis better, to make the teens come back to buy from that. So, but you know, people were not even aware that they were using amphetamines. So, you know, that again gives another argument for prescribed cannabis as being part of a harm reduction strategy for safe supply. So moving on to the management, whether we've assessed somebody as having a cannabis use disorder or dependence, or just wanting some help to get control over their cannabis use. The conventional treatments that we have for cannabis use disorder aren't that great. Most people will return to regular cannabis use without some form of other intervention. There's a list up on the screen of the very common psychosocial or psychological interventions that are known to help. I really love motivational interviewing. We do this so well in primary care, and a lot of that stuff that's up there is you know, bread and butter for primary care people. But I do like to kind of bring my mind back to that original question around, why do you take cannabis? You know, is it to manage your stress? Is it to get to sleep? And knowing the reason behind somebody using can then help you target where we want to target these psychosocial interventions. Okay, prescribed cannabis for cannabis use disorder. And I think, you know, knowing that research is ongoing in relation to finding medications that will be helpful. And again, coming back to our goal, what is our goal here and which model should we use? And I think both of them have merit here. I think when you've gone down all of the avenues for conventional treatment and you've tried everything, whether that's withdrawal, which we'll talk about in a minute, you've done all these psychosocial interventions, you've addressed triggers, you've looked at you know, the other things that could be, I guess, exacerbating or contributing to somebody's cannabis use, then I think, you know, considering prescribing cannabis, I think that I would certainly do that. I certainly do that. And whether that's like the OTP model or the opioid treatment program model, where we're prescribing methadone and buprenorphine with the idea of it being long-term, so like a substitution therapy, or whether it's like the NRT model where, you know, we're prescribing patches and gums or sprays for a brief amount of time to let somebody come off the substance. And what about prescribed cannabis for withdrawal? So actually using cannabis in the withdrawal process or in the withdrawal phase to help people's withdrawals. And I think, you know, there's been a fair amount of evidence which has shown efficacy for using prescribed cannabis in the withdrawal program or in the withdrawal process. But without anything else to go with it, everybody goes back to using cannabis like they were before. And I'm going to share with you the Clean Slate Protocol in a minute, but the wonderful thing about all of the Clean Slate programs is that it's not just about withdrawal. And I often say to my patients, withdrawal's the easy bit. You know, you've got one-on-one support every day. You're ready. You're in the zone. You're motivated. You're at your peak of, you know, commitment and motivation to this process. And we're giving you medications to help you manage those withdrawal symptoms. It's what comes after the withdrawal that really makes or breaks somebody's recovery. And we'll talk about that a little bit more when I share the protocol with you. So withdrawal management. What is the withdrawal syndrome? So it's a cluster of symptoms like an alcohol withdrawal syndrome or an opioid withdrawal syndrome that happens on cessation or a marked reduction in somebody's cannabis use. And I'll show you a graph on the next slide about the protracted withdrawal and the phases that the withdrawal goes through. But we know that a third of people who use cannabis less than daily will develop a withdrawal syndrome, and 50% of people that are using cannabis daily will. If somebody is using cannabis daily, I assume that they're going to have a withdrawal syndrome, whether that's prescribed or whether that's non-prescribed. If you're using cannabis every day, you will most likely experience a withdrawal syndrome on stopping. And what does that look like? Changes in sleep, a real fatigue, changes in mood, some gastrointestinal symptoms, whether that's nausea, or yeah, I'll leave you guys to read that through. I'll leave you folk to read that through that. But definitely the sleep and those, whether it's hypersomnia or insomnia, is certainly something that is a trigger to people going back to using it, going, this is too hard, I'm not going to do it anymore. But if we can manage these withdrawal symptoms in a way that enables the person to be able to move through the withdrawal phase, the protracted withdrawal phase, then their chances of actually achieving their goals are a lot greater. So it's all about symptomatic management, and even simple things like Panadol, ibuprofen, keeping people nice and hydrated, making sure people are sleeping. That's a really terrible slide, and I apologize. I couldn't fix it. I did try to blow it up, but it just got blurrier. This is the cannabis withdrawal scale, not to be confused with the COWS or the clinical opioid withdrawal scale, which almost has a similar acronym. But that will be easily available for you to Google. And this is the withdrawal scale that we use as a scale of 1 to 10 on how much you're experiencing. A patient is experiencing these symptoms, and it just gives you a score to enable you to objectively assess this person's subjective and objective experience of withdrawal, and enables you to then guide treatment. So this is that graph on the time course of withdrawal, and you can see that there's 3 distinct phases. That green line there, gee, I've done well with the graphics tonight. I've managed to cut off the green line, the what do you call that when you got
Y-axis?
the y-axis, the legend.
Y-axis.
But that's the percentage concentration of cannabis in the system, and you can see that drops quite significantly over the first 4 days, and then gradually levels out to well over a month. But that first phase is characterized by not being able to sleep, being really restless, losing your appetite, and that kind of sweaty chills feeling. And then after that acute phase passes, then we head into the real mood, irritability, anxiety, restlessness peak at around the week mark. And then after that, anywhere between, kind of 10 and 16 days, you can get a real anger and aggressive symptoms coming out. And then they kind of taper off at 21 days, but I've seen cannabis withdrawal last longer than that. So knowing that in advance, it's that forewarned is forearmed, and for patients knowing that they're going to go into this and they're going to be feeling pretty shitty for a couple of weeks, and knowing that you might need to be providing not necessarily medication or pharmacological support, but really solid support to that person to get them over that mark until they're through that withdrawal phase.
It's such an important point, and it's sort of why not all withdrawal questionnaires or scales are validated as much as the CWA is or the COWS is. But what's really nice is to just help people reframe their symptoms in a way. So they may say, I can't sleep if I don't smoke, or I started smoking for my insomnia, just to pick on that symptom, and to be able to show that it actually, insomnia is a withdrawal symptom. This is something that you're going through because you're withdrawing from the drug, as opposed to a reason why you were using it. And these are the things that we expect people to go through. They can frame those withdrawal symptoms as a positive aspect of what they're doing. You know, I know I have to suffer these things, but I know they will go, and the benefits will come after that.
Nice one. So this was a study published in JAMA in 2019. So the question the study asked is cannabinoid agonist treatment in combination with psychosocial services a safe and efficacious approach to reducing illicit cannabis use in patients with cannabis dependence who are seeking treatment. And the guts of it is, look, yes, it may well be. There were fewer days of illicit cannabis use compared to placebo, and it was really well tolerated by participants. So it's my understanding that these studies are being, replicated, and that evidence base is building. So the exciting bit of the webinar, our protocol. And as we go through this, please feel free to take screen grabs, take photos, write things down, ask questions. If you have anything that you want to offer or add, we'd love to hear about it. Any of your learnings that can help us do our job better, we would love to hear about that as well. Our protocol, this is straight out of the Clean Slate policy, that we want to assure safe and consistent management of cannabis withdrawal in a home setting via telehealth, that we're committed to using the best practice approaches, and that we do our best to ensure client safety and avoid medical complications. So the process is probably easier just quickly, our inclusion and exclusion criteria. Inclusion criteria, 16 years old and over, recently reduced from 18 years and over. So it's really exciting to be able to offer this service to 16 and 17-year-olds who are seeking cannabis withdrawal. Exclusion criteria, you'll see that they're in little inverted commas. And the reason for that is part of our process, or part of our protocol, is about assessing people as being suitable and safe for our program. And if somebody does have one of these exclusion criteria, we kind of call them more caution criteria, or things to watch out for, or things to bring to the team. And the team will have a discussion around whether or not this is safe, how we can work with the patient to mitigate the risks that might happen. How do we work in collaboration with people already involved in caring for the patient, if that's the GP, if that's a psychiatrist, if they're care workers, if they're whoever else is already involved. We don't want to replace, we don't want to compete. We want to provide a service where it doesn't exist, and we want to provide a service that's safe and specific for the people that are trying to access it. So we have exclusion criteria, but they're relative contraindications, so to speak. And if in doubt, if you have a patient that you think might be suitable for our program, and you want to talk about it, then we're all super happy to chat at any time and try and decide whether or not somebody would be. I'm right about that, aren't I, Chris? Yeah.
Sorry, I'm just writing an answer.
Sorry. I was going to say, if people aren't certain about whether or not a patient might be suitable for our program, then they're most welcome to give us a call, and we can have a chat and determine whether or not it's something that's worth exploring.
Absolutely. I mean, there's no real absolute contraindication to withdrawal with Clean Slate, particularly with cannabis, but also with the other drugs. We will assess everyone independently, and our intake team include nurses, and if they've got clinical questions, we have a duty nurse, duty doctor. So we won't sort of take people through if we really think they are too complex.
So stage one of the program, people will come across our program, whether it's via referral, whether it's via word of mouth, whether it's via our socials, whether, however they find our way to us. They will start with an online assessment, and then that gets triaged, or that gets assessed and passed on to one of our incredibly exceptional, specifically trained AOD nurses who will do an initial appointment that goes for 45 minutes. And, that pretty much follows, the basic kind of history taking, looking at goals, looking at suitability for the path forward. They'll then have a second nurse appointment, which goes into a little bit more detail, a little bit more of the planning phase. And that their support person will be present at that appointment as well. Did you want to add anything to that, Chris?
Yeah, so although we call it assessment and preparation, the actual treatment and management really starts right there as well. So we use cannabis diaries, which are really a nice proven CBT tool of holding up a mirror about your use and identifying triggers to use, who are you using with, what time are you using, how do you feel when you use, what are the consequences of your use. We've got some resources that we use like pros and cons list, and so we're really sort of starting the treatment right from the beginning. So the assessment is assessment, absolutely, but also like an extended intervention as well.
Yeah, and again, it's not just about cannabis. We're considering the whole of person in this workup and in this assessment, and running through those questionnaires, looking for anything else that we can flag or that we can support them with. So after that preparation phase, they'll then come to the actual withdrawal phase, and that involves a doctor's appointment. So it will either be with an AOD GP or an addiction physician. They then proceed through the 5-day withdrawal in their homes with daily check-ins from our nurse specialists who review their symptoms, look at their cannabis diaries, take their blood pressure, looking for any side effects, adverse reactions, communicating with the support person, communicating with the GP as required. And I'll show you the medications that we use. I think it might be on the next slide. Yeah. And this is our medication protocol for, there's a spelling mistake, withdrawal.
It's a capital I.
Yeah, a capital I and is that why it's done that? Yeah. So again, if we remember back to the phases of the cannabis withdrawal, just looking at the potential for symptomatic treatment at any particular stage, where 20 milligrams max in a 24-hour period is not really a great big dose, and 5 milligrams of olanzapine in 24 hours again is not an overly sedating dose, depending on people's use, and then just managing their physical pain and potential headaches with simple measures of paracetamol and non-steroidals, and any nausea they might be getting, whether that be Maxilon and or ondansetron.
Yeah, so unlike alcohol or opioids, it's really just purely symptomatic management that we're using at Clean Slate, and I guess that's where the role for the nabiximols and as a bit of replacement therapy as well. It'll be interesting to see how that will fit into a medication regimen as we go forwards with any sort of guidelines or evidence that follows.
Yeah, definitely. And this is where it would come in.
Yeah.
So then stage 3, which is the recovery and aftercare program, after the withdrawal phase, they'll be then reviewed again by their doctor, the same doctor, or usually the same doctor that did their pre-withdrawal assessment. And they'll go through a process of reflecting on the withdrawal, reflecting on some of the learnings, their experience, looking at any complications, and then developing a plan for the way forward, which then includes 12 months. So it's really longer than a 12-month program. It probably ends up being 13 months all in all. But all of the follow-up appointments are booked. There's a telehealth group of smart recovery groups, which people are invited to, and then signposted, I guess, to any other services that might be supportive of them in that 12-month program. And then they stay with us for another 12 months. Did anyone have any questions on that protocol before we move on to just the different referral pathways, which I might just leave up on the screen while we're taking questions and having a little bit of a discussion if time permits.
Yes, we've had a few questions. So Stephen Wu was asking about the ideal approach to insomnia and/or nightmares when they stop cannabis. I've answered it in text. So if you're going to answer live, read what I've said. So see if you get it.
You shouldn't, just so I can't see the chat because I'm sharing my screen. But I was going to say maybe I shouldn't to see if our answers are
Yeah, go. Yeah, you go.
Well, I would just revert back to the protocol and have a look at, try and maybe elucidate which phase of the withdrawal they're in. But if they're getting nightmares, then I would use the combination of diazepam and olanzapine in that setting. Is that what you said?
Yeah. You hadn't talked about medications yet, so I left that as a bit of a secret.
Fair enough.
But I think, yeah, particularly like low dose olanzapine is really nice for those
The
intrusive
nightmares.
thoughts. People do get a bit of paranoia. Well, when they're smoking, and certainly that should be part of your assessment. But also when they stop. So I do find that low dose olanzapine can be helpful for some people. And again, those lower doses of diazepam can really help that initial insomnia as well. I went all GP and spoke about I mentioned sleep hygiene and CBTI and those sorts of things, which are always
Absolutely. Yeah, no, totally. Yeah.
Stephen also asked, so Stephen asked about if we get people to sign a contract before starting cannabis replacement therapy. So we don't use cannabis replacement therapy. We at Clean Slate, we don't prescribe any medicinal cannabis. We've made a sort of conscious decision to not do that at this point in our sort of social enterprise journey. We're really a withdrawal and recovery service rather than a cannabis prescribing service or indeed a general practice dealing with chronic pain or chronic disease management, although obviously these use disorders are chronic diseases. So we're sort of staying in our lane with that. And Stephen says he finds a lot of his patients come for their mental health care plan, but fail to follow through with the plan and don't return for review until 6 months' time after they've run out of the benzos or opioids or Centrelink medical certificate. I mean, certainly I would never give anyone 6 months supply of benzos or opioids. So if I had someone on a script for benzos or opioids, I would have them on very regular reviews with a weaning schedule organized with that client. And I certainly would have, I had a separate, and we do have separate benzodiazepine management contracts that we get patients to sign, and also opioid contracts where they agree to only have one prescriber, one pharmacy, not to use other benzos, agree to regular UDSs and safe script checks. I'm not sure if that answers that question. I did click that we'd answer a question live, but it was about asking patients. I just pressed the wrong button. So do you require the patient to have their own BP monitor? And if so, do you mandate a particular model or brand? It's more important really with the alcohol, perhaps the amphetamine pathways rather than the cannabis pathway. I would say certainly when we're doing daily dispensing, we get the chemist to check the blood pressure on a daily basis if the client doesn't have their own BP monitor. And I don't. I'm not on getting paid by anybody other than Clean Slate and St. Vincent's, but Omron is the one that I'm used to, and you can get a cheap $60-$70 Omron with no bells and whistles, which is all they need for about $60-$70. And then Sean has asked, do you ever use prazosin for traumatic nightmares? And I've had really good results with prazosin for traumatic nightmares, and so yes is the short answer. There's some reasonable evidence for that. According to a psychiatrist who I work quite closely with, it really only works best for, as you say, Sean, the traumatic nightmares. So if someone is actually reliving a trauma, having like a flashback, they're reliving a traumatic event in their nightmares, that's where prazosin seems to work the best, rather than if you're having general nightmares about monsters under your bed. Um, and I really like prazosin for that. There is some sort of low level or promising evidence that prazosin can help with use disorders on its own, separate from nightmares. They've done some studies using prazosin TDS for alcohol use disorder, which were better than placebo. So as long as you're warning people about hypertension and potential side effects, I like it because it can help people sleep without that addictiveness. So yeah, I quite like it, to be honest. Do you use prazosin, Bron? Is that something
Yeah,
you?
I do. I do, and exactly for the same reasons that you said. It's not something that I've prescribed through Clean Slate, and I think it's given that it's something that requires ongoing management and titration, it would be something that we would recommend that our patients discuss with their GP. But yeah, I agree. I think it's yeah, definitely efficacious.
Yeah, Sean also uses it and has had good results with it. And I think that's an important point that Bron's brought up. I mean, again, we pretty much stay in our lane at Clean Slate. So we will prescribe medicines for withdrawal for short-term use, or unless they're anti-craving medications. But again, we tend to very much stick with on-label evidence-based medications because we're pretty light touch with what we can offer when it comes to medical appointments, because we're a social enterprise and we're trying to keep this what we are as affordable as we can for our clients. So we're very much helping people with their use disorder and relying and communicating with their local GPs. And so that's why really naltrexone and Camprol are the only two sort of anti-craving medications we use, because they are PBS listed with strong evidence base, they're safe, they're effective, and we have no qualms about asking our GP colleagues in the community to continue those prescriptions. If we were to start prazosin or baclofen or something off-label, then we wouldn't feel comfortable asking our GP colleagues to continue those prescriptions.
When it comes to communicating with GPs, I love that when a patient joins the program, part of the protocol is that that an initial nurse assessment. The nurse will send a letter to the GP requesting a health summary saying this is the patient, they've contacted Clean Slate. Then after the initial doctor's assessment, they'll get another letter with if there's an intention to withdraw. So there'll be another letter sent to the GP saying, we've seen your patient today, they're intending to withdraw. This is the date of their withdrawal. And then the GP will get another letter at the end. So we're not spamming you. We're making a conscious, concerted effort to collaborate, to keep informed. Our letters always offer, or mostly offer, mine always offer, but mostly I can't speak on behalf of the other doctors, but we do talk about wanting to be included in GPs' management plans and team care arrangements, and we're trying to really embody that multidisciplinary, collaborative. We're all in this together. Let's work together for the best possible outcomes for the patient. So if you get 3 letters from Clean Slate, and then you'll get a treatment plan as well. So it's really about trying to keep you informed and really improve those lines of communication from us. From outside into general practice, which I know as a GP myself is something that's not, done very well elsewhere.
Basically, if someone goes through a detox with us and you get a letter from us, then it's sort of it's like free reign to do a GP management plan. So you can do it just on the strength of what we've done. You can fill out a GP management plan, because if they've gone through an alcohol withdrawal or cannabis withdrawal, they have a use disorder. And I've checked this with Medicare because I did a lot of those as a GP. So a use disorder is seen as a chronic disease, as it should be. So they are eligible for a GP management plan. We would fulfill the requirements of a TCA. So you get 721 and a 723, if I've remembered those numbers correctly. And we will never bill for those things. We don't get any Medicare billing. So yeah.
That's important to note as well too, that that there is we don't we don't feel Medicare. I don't know if that's worth talking about, but probably not because it's 7:35.
Yeah, I just got one last question from Anthony. Hi, how are you? Thank you for joining us. So he's asked, do you still have low fee places on your program? I know you had some back a while ago with PHM funding. And if you're private paying, what is the cost? So yes, we still have government contracts in Western Queensland. In fact, we're the only withdrawal service available in Western Queensland. If you're not eligible for us, you have to fly out to Brisbane through the Flying Doctor service. Also in Western New South Wales, we have PHN funding for places there. For Central Eastern Sydney PHN, we have a handful of places for people who can't afford to pay, and Northern Sydney PHN. We now, I'm really pleased to say, are funded by 18 private health insurers. And if you don't live in one of those postcodes or have a health fund, we also accept DVA, so it's free for people with a DVA gold card. We are doing work with women's community shelters to break that cycle of violence. So now people can go to a shelter if they're drinking. We can help them detox in the shelter, which they couldn't do before. We've also working with Gundeer Health in St George in Western Queensland, and also in Armidale in Northern New South Wales with those ACHOs. So if you're part of those Aboriginal medical services, then we've got free places there. If someone really, you believe Clean Slate is the only or best service for them and they have no funds, please again contact us. We do have limited amounts of philanthropic funding that we can ask for, and we can ask local PHNs as well for funding. It's the full cost of the program is $3,750 for the full 13-month program. We do offer payment plans, which brings that down to $350 a month, which is less than half of what people are spending on alcohol on average, given the drink diaries and the rich data that we've been getting. So yeah, it's if you're coming on the drinking pathway, then it's a cost saving program for you. Not always an easy sell, that though. Exactly. Thank you. It's a bargain. I think so. Brilliant. Are there any last questions before I let Bron go and have her dinner?
I think there's enough light for me to take the dogs for a quick walk to the beach.
Brilliant. All right. Well, thank you so much for joining us, and thanks to the incredible Bronwyn Hudson for entertaining us with fantastic information and education as well. Lovely.